केसेस की लिस्ट है। तो ये एक किस्म की आपकी आंट मिनी की लिस्ट हो सकती है, ठीक है? तो ये आपको सारी आनी चाहिए, इसकी डिजीज़ेज़ आपको पता होनी चाहिए, इसके मुख्तलिफ केसेस, मुख्तलिफ वैरायटी ऑफ केसेस आपने देखे होने चाहिए क्योंकि आपके एग्ज़ाम में आ सकते हैं, ठीक है? और अगर इनमें से कोई केस आपका गलत हो गया तो व्हिच इज़ दिस इज़ नॉट अ गुड थिंग, वो आपको एक बहुत ही बैक फुट पर ले जाएगा एग्ज़ामिनर के सामने, ठीक है? क्योंकि ये बहुत कॉमन, बहुत ही एसेंशियल चेस्ट इमेजिंग केसेस हैं, ये आपको सारे आने चाहिए। तो जिस तरह ये भी था एक सिस्टिक फाइब्रोसिस का केस, आपने बड़ा अच्छा इसको हैंडल किया। आपने इसमें मैं होता तो मैं आपको 6 मार्क्स देता। 6 और 6 ये 2 इवेंट्स काउंट होते हैं। तो जो कि एफआरसीआर 2बी वाइवा में ये होता है कि चेस्ट एक्स-रे अलहदा इवेंट काउंट होता है और चेस्ट सीटी स्कैन आपका अलहदा इवेंट काउंट होता है। ये दोनों सेपरेट इवेंट्स में आपको 6 और शायद सीटी में आपको 8 दूँगा। लेकिन आप दोनों इवेंट्स में ज़्यादा नंबर ले सकती थीं। तो अपनी जो 8 मिनी केसेज़ हैं, वो आपके बहुत अच्छे प्रिपेयर होने चाहिए। उसमें यू शुड थिंक ऑफ अहेड, आपको एसोसिएशंस, कॉम्प्लिकेशंस के मुतालिक आपको सोचना चाहिए जब वो आप उनको डिस्क्राइब कर रहे हो। तो ये 8 मिनी केसेज़ हैं, तो ये दे शुड बी ऑन योर प्रायोरिटी लिस्ट। तो डिफरेंट एग्ज़ामिनर डिफरेंट होते हैं। कुछ लोग ये 8 मिनी केसेज़ शुरू में ही दिखा देते हैं, कुछ लोग इसको आखिर में रखते हैं। तो आपकी जो डिस्क्रिप्शन की स्पीड है वो भी अच्छी होनी चाहिए क्योंकि आपके पास 20 मिनट्स है, 20 मिनट्स में आपका वाइवा खत्म हो जाता है। 15 टू 20 मिनट्स है आपके पास, तो आपने उसके अंदर ज़्यादा से ज़्यादा केसेस देखने हैं ताकि कोई 8 मिनी केस उसने रखा हुआ है तो आप उस तक पहुँच जाएँ। क्योंकि मैंने अक्सर लोगों को देखा है कि वो एक केस पर स्टक हो जाते हैं, वहीं पर स्टक रह जाते हैं, तो वो 8 मिनी केस तक उनकी बारी नहीं आती, ठीक है? तो टाइम जो है ना वो एफआरसीआर 2बी में वो आपकी रिस्पॉन्सिबिलिटी है। एफसीपीएस में भी जैसे होता है वो आपकी रिस्पॉन्सिबिलिटी है, आपने खुद ही टाइम का ख्याल रखना है, ठीक है? तो यही चीज़ें आपको पता होनी चाहिए कि 8 मिनी केसेज़ को आप प्रायोरिटाइज़ करें। सबसे पहले आप 8 मिनी केसेज़ को कवर करें एफआरसीआर 2बी की तैयारी में। उसके बाद आप रेयर केसेज़ पर, कॉम्प्लिकेटेड केसेज़ पर या ऐसे केसेज़ जिसमें डिस्कशन होनी है उसकी तरफ जाएँ। ठीक है? और बहुत ही ज़रूरी है वो आपको कुछ ना कुछ 8 मिनी केसेस दिखाएँगे। अगर आपके फुल वाइवा हुए तो उसमें 3 या 4 8 मिनी केसेस ज़रूर होंगे जिसमें आप बहुत अच्छे मार्क्स ले सकते हैं, ठीक है? तो इस पर फ़ोकस होना चाहिए। ये कार्डियक इमेजिंग के 8 मिनी केसेस हैं, ये लिस्ट मेरी अपनी बनाई हुई है। तो सबसे पहले अगर आपको कार्डियक इमेजिंग दिखाई जाएगी तो आपको नॉन कार्डियक पैथोलॉजीज़ उसमें दिखाई जाएँगी या फिर सिस्टेमिक पैथोलॉजीज़ दिखाई जाएँगी, जैसे कार्डियक मेटास्टेसिस आपको दिखा सकते हैं, एमाइलोइडोसिस दिखाया जा सकता है, सर्कोइडोसिस दिखाया जाता है। तो ये चीज़ें आपको दिखाई जा सकती हैं। वेस्कुलर एनोमलीज़, एब्नॉर्मैलिटीज़ उनकी बहुत फ़ेवरेट हैं या इमरजेंसीज़, कार्डियोवास्कुलर इमरजेंसीज़ हो गई। तो पीई बहुत इम्पोर्टेंट है, कोआर्क्टेशन ऑफ एओर्टा इम्पोर्टेंट है, पर्सिस्टेंट लेफ्ट एसवीसी, इस तरह की उसमें वो बहुत ज़्यादा इंटरेस्टेड होते हैं जिसमें वो आपसे एनाटॉमी पूछ सकें, आपसे एनाटॉमी डिस्कस कर सकें। यूजुअली हमारे कैंडिडेट्स वहाँ जाते हैं, वो ये समझते हैं कि उनसे सिर्फ़ पैथोलॉजी ही पूछी जाएगी, तो वो ये केसेज़ ख़राब कर देते हैं। तो ये बहुत इम्पोर्टेंट है कि आपका फ़ोकस हो, आपको चेस्ट जो है ना रेडियोलॉजी या चेस्ट इमेजिंग की एनाटॉमी पता होनी चाहिए, वीनस और आर्टेरियल एनाटॉमी आपको पता होनी चाहिए, कार्डियक एनाटॉमी आपको आनी चाहिए, क्योंकि आपसे उसके हवाले से एनोमलीज़ और एब्नॉर्मैलिटीज़ आपसे पूछी जा सकती हैं, ठीक है? कार्डियोवास्कुलर इमरजेंसीज़ बहुत ज़्यादा इम्पोर्टेंट है, मायोकार्डियल इंफार्क्शन का केस आ सकता है, थ्रॉम्बस का, लेफ्ट वेंट्रिकुलर थ्रॉम्बस का केस आ सकता है, ठीक है? डिसेक्शन का, एन्यूरिज्म रप्चर का केस आ सकता है। तो ये जो शुरू वाली 3 चीज़ें हैं बहुत ज़्यादा इम्पोर्टेंट है, आप पहले इन चीज़ों को कवर करें कार्डियक इमेजिंग में और फिर आपके पास अगर टाइम बच जाए तो कार्डियोमायोपैथी की तरफ जाएँ, वरना मेरे ख्याल में अगर आपको कार्डियोमायोपैथी का केस दिखाया गया है तो इट इज़ नॉट अ फेयर गेम इन एफआरसीआर 2बी वाइवा। लेकिन आ सकता है, कोर्स के अंदर है, ये आउट ऑफ कोर्स नहीं होगा अगर वो आपको दिखा भी दें। ठीक है, तो हमारी फर्स्ट टिप थी कि 8 मिनी केसेज़ आप सबसे पहले कवर किएँ। अगर आप एफआरसीआर 2बी की तैयारी कर रहे हैं, तो सबसे पहले आप 8 मिनी केसेज़ हर जो सेक्शन के हैं, उसके सारे कर लें। 8 मिनी बुक है, यहाँ से भी कर सकते हैं और भी एफआरसीआर 2बी की डिफरेंट बुक्स हैं, तो वो कर सकते हैं। ठीक है? अभी हम जाएँगे केस 2 की तरफ, मैं क्वेश्चन देख लूँ। एमआई केस ऑन न्यूक्लियर इमेजिंग, नो मायोकार्डियल इंफार्क्शन जो है ना, जो कि यूजुअली एक्यूट मायोकार्डियल इंफार्क्शन को हम देखते हैं, उसके लिए हम न्यूक्लियर इमेजिंग नहीं करते। हम वो एमआरआई, कार्डियक एमआर पर देख लेते हैं। एक्यूट भी, क्रॉनिक भी हमें पता चल जाता है, वायबिलिटी भी पता चल जाती है उसके अंदर। अ, वायबिलिटी हम उसको कहते हैं कि हम कितना मायोकार्डियम बच गया है, कि हम इसको रीवेस्कुलराइज़ कर सकते हैं कि नहीं कर सकते हैं। एमआई तो हो गया है, कितना जो मायोकार्डियम है वो अभी भी वायबल है, उसको देखने के लिए हम वायबिलिटी स्कैन करते हैं। ये सारी चीज़ें एमआर पर, अवेलेबिलिटी स्कैन हम न्यूक्लियर स्टडी में भी, इमेजिंग में भी कर सकते हैं, ठीक है। लेकिन MI केस अगर आपको दिखाया जाएगा तो वो कार्डियक MR पर दिखाया जाएगा, न्यूक्लियर पर नहीं दिखाया जाएगा। कब एक्सपेक्टेड है टू बी इन पाकिस्तान? वी डोंट नो, वी आर ट्राइंग फॉर इट, इंशाल्लाह सून, आई थिंक इन अ कपल ऑफ इयर्स इंशाल्लाह, ठीक है। कैंडिडेट 1, आर यू रेडी? हम अभी सेकंड केस की तरफ जाते हैं, ठीक है। Okay, so can you see the case?
Yes, sir.
So 70-year-old female with 1 week of productive cough.
I'm provided with X-ray chest of the 70 years old female whose primary complaint was productive cough since 1 week, and I can see that there is a opacity in right upper lung zone. Um, can I, sir, zoom it a little?
Yes. You're on mobile or you're on your laptop?
Sir, I'm on the laptop here.
Okay. Yes, you can get closer to it.
Regarding the margins of the pulmonary opacity, it's look like pulmonary in origin and they are well defined. I assume that there are certain specks of calcification within this lesion. I would like to further zoom this image on my workstation to look for underlying
Can you point out the
calcification.
lesion? I'm sorry, can you point out the lesion?
Sir, it's above the clavicle. Sorry, it's overriding the clavicle and right rib. Uh, in my usual routine practice, I usually do some windowing to make sure that it's a true lesion which I am referring to. And if it's a true lesion, it looks like a pulmonary opacity. I would like to further investigate this patient on. First, I would like to see any previous imaging if available. And if it's a new lesion, I will categorize it on CT scan. Apart from that, I see that I'm looking at the bones of this patient. It's an old age patient, so I am worried about any uh, malignancy or any metastatic deposits. The patient presented with productive cough, so I am looking for airway diseases. I see that bilateral hyla are unremarkable. Pulmonary vessels are within normal limits. Retrocardiac area uh, shows some prominent pulmonary vasculature only. However, I do not see any pulmonary nodule or any mass-like lesion. Uh, Regarding rest of the lung parenchyma, I do not see any nodule or abnormal mass. Now I'm looking for the areas below the diaphragm. In my routine practice, I usually window the image to further look for any details. Also, I look for details in paraspinal region. I'm looking at the humeral head. Right humeral head is not um, covered in the available film. Left humeral head appears normal. So, in summary, this is a patient with a suspected opacity in the right upper lung, which which needs further investigation and comparison with previous X-ray. Some prominence of bronchovascular marking also noted in right paracardic region, which could be infective in nature and is may be suggestive of the reason why the patient is having productive cough. Could be suggestive of bronchitis only. I cannot see the breast shadows. I cannot see on this film. However, I don't see any mastectomy clips either. So I would inform my findings to the referring clinician and uh, investigate this patient further.
How would you like to investigate this patient?
Sir, I would like to investigate this right upper lobe nodularity which I see. So I would go with the CT scan of this patient.
CT scan what?
CT scan chest, an enhanced CT scan chest of the patient.
An enhanced CT scan chest of the patient. And what is your diagnosis?
So this is ill-defined nodularity in right upper lung. So in old age patient, we could be thinking of any primary lung malignancy with and also infective etiology. We cannot rule out, but it's not the ideal location for an infective consolidated patch. Neither it's a morphological feature of a infective etiology. Apart from that, the right lower lung zone prominence bronchoscopy markings looks like infective in nature. So I am not very well, um, convinced with the appearance of this right uh, sided upper lobe nodularity. So for that, I need to investigate this patient further, whether it's pulmonary or extrapulmonary in nature.
Okay, so what is your diagnosis? I'm sorry. What is your final diagnosis? What is your single diagnosis?
So in this case, a single diagnosis would not fit, as I am not much convinced it to be a nodule per se. So I would see for any previous imaging if available. If not, I would consider it as a solitary pulmonary nodule right upper lung, and for that reason, CT chest I need.
Okay, this is the CT. Can you ask for remote control?
Recording in progress.
Yes.
Yes.
Provided with post-contrast CT chest axial section of the same patient, which shows a speculated mass conforming to the site of previously mentioned nodule in the X-ray. This mass is having adjacent parenchymal slight fibrosis, evident as speculation. No internal calcification is apparent. By the look of this, I would like to go through all the scan before I jump to some conclusion. I'm looking for any multicentric lesion. I see that there is right-sided pleural effusion with an area of, there is a thick wall cavitary lesion in the right basal lung as well. Some basal consolidation is evident in right bibasal lung. I would inquire how, I would like to see if this CT has been taken immediately after the X-ray has been taken, because if it has been taken within um, after quite some time, then there is interval development of bilateral basal consolidation with pleural effusion, which could be infective in nature. The right upper lung nodule with speculated margins is worrisome for any primary pathology and needs further investigation with lung biopsy. This lesion is not associated with any. I would like to see the mediastinal window, sir. to look for any mediastinal lymph nodes.
Okay, here is the mediastinal window.
Yeah, on mediastinal window, this lesion is slightly hyperdense, which is of on mediastinal window, I see that major mediastinal vessels are normal and there is no enlarged lymph nodes. I am also I also want to see for the bone window to look for any bony pathology and look for any signs of metastasis. This lesion looks like a primary lung lesion. The basal lung pathologies are likely infective in nature with reactive bibasal pleural effusion. So bone window I would look for, and I would look for per-abdominal images of the CT scan to look for any metastatic deposits in the visualized liver parenchyma, which I cannot see, and it looks normal. The lung in the right basal region enhances normally, which is again um, convincing towards a consolidative patch.
Okay, so what is your
I am,
diagnosis?
sir, it's a primary. I'm actually looking for the esophageal area. I just confirm it once and then I will conclude it. Yeah, there is a slight herniation only, hiatal hernia. So in summary, it's a primary lung lesion involving right upper lung, which needs further investigation with lung biopsy. I would refer this patient to pulmonologist in view to uh, settle her acute findings in terms of bibasal consolidation and pleural effusion. Further, refer this patient in the MDT after lung biopsy. I would like to complete the study after looking in the bone window to look for any signs of metastasis and convey my findings to the pulmonologist.
Okay, so you're sending the patient for biopsy first, yes, to the pulmonologist to do the biopsy.
I think first we have to stabilize this patient as the patient is having a consolidation and pleural effusion. So this patient must not be an ideal candidate for lung biopsy per se. So first the acute findings should be settled and then the biopsy should be planned accordingly.
Like if the patient is clinically, or do you want for the patient to wait till the pleural effusion
Uh,
settles?
yeah, sir, because lung biopsy has its complications as well. Uh, so in a setting where already patient is having pleural effusion and consolidation and must be having, she is having some kind of cough. So in that scenario, she will not be able to tolerate a lung biopsies. In that scenario, we would be waiting for her primary clinical symptoms to settle down until we plan our proper biopsy.
So you will wait. So if it took 6 months for it to settle down, and meanwhile the tumor spreads to the bones, how will you justify that?
Um, so we look for benefits versus risk. If the patient and the pulmonologist team allow, then we can refer it for biopsy in the first place. But
Okay,
ideally, patient should be clinically stable, vitally stable to go for any invasive procedures which do have the complications like pneumothorax. So that's why patient should ideally be stable enough to go for biopsy.
is this a contraindication?
No, so it's not a contraindication. It's we can perform if the MDT allows. We can perform.
So you want to send it to MDT or you want to send it to pulmonologist?
Sir, I will send it to MDT, and then
MDT
if
to
MDT,
pulmonologist.
yeah, sir, sir, pulmonologist will be in the MDT now, sir. So they will look for it.
Okay, so you need to correct your approach towards this. Okay,
Okay,
uh, initially you need to do a staging CT. Staging CT is first. Okay, so if you
okay,
have
sir.
found something,
Okay, sir.
do staging CT proper, because you never know, it might be having widespread metastasis. Okay,
Okay,
and there might be a simpler biopsy target rather than this. And in some cases, they may not even need biopsy. They will discuss it, and they will discuss in the MDT the performance score is not right for the patient. There are some pre-biopsy checks, and the patient may not be a suitable candidate for biopsy, so they may not do a biopsy. So initial first should be a staging CT. Without staging CT, saying that I would like to do a staging CT first, you should not recommend or do biopsy. Second thing, what I would like to be, which is I think a better wording than saying that I recommend a CT guided biopsy, is the patient is amenable for an image guided biopsy, rather than saying go and do the biopsy, because you don't know the clinical details of the patient. You don't know whether the patient is willing for any treatment. Some of the patients in UK, they say they don't want any treatment, they don't want any invasive procedure, they just want to be left alone. So you don't know about the performance score of the patient, you don't know about the lung function of the patient. So before recommending something which is a clinical decision, you can comment like this, that this patient is amenable or the percutaneous biopsy is possible in this patient. Your wording should be like that, which is more suitable, which makes more sense. Okay?
Okay, sir.
And then you can say initially staging CT, you should talk about staging CT. You have not staged the patient, so first staging CT, then biopsy. Third step in lung cancer treatment is a PET CT scan. So you should refer the patient for PET CT scan, then you will discuss the patient in MDT. So without having a staging CT, how can we discuss a case in the lung cancer MDT? So there will be no use of discussing this case. So your referral will be wrong. If you send this case to a lung cancer MDT, this is completely wrong. They will say that who has referred this case to lung cancer MDT. So initially you will do a staging CT scan, so that the lung cancer is completely staged, so that we can decide about the different treatment or management options. Secondly, you will comment whether this is amenable to an endobronchial biopsy or a percutaneous image guided biopsy. You should comment on that if possible. They may ask you about that. Thirdly, you will have a PET CT. PET CT is better in staging of the lung cancers. It is more valid, and particularly for T staging, it is more valid. And sometimes it also helps us in targeting if there is a large lesion. It helps us in targeting area of biopsy as well. So PET CT is also mandatory, and then the discussion in the lung cancer MUT. This should be the pathway. This should be the pattern. Okay. So otherwise, if we do like that, the pleural effusions and this infection is not an contraindication to biopsy unless patient is completely extremely symptomatic and cannot undergo the biopsy. This is a different thing, but these little things are not contraindication to
Sir,
biopsy. Yes.
sir, for any cancer, what I had in my mind that unless we don't have a histopathological diagnosis that it's a cancer, how can we give so many radiations to the patient in terms of staging CT or PET?
No,
So
staging CT is mandatory. So
mandatory.
if
Okay. So
let
for
me tell
any
you,
cancer, for
for any
any
cancer,
cancer,
for any cancer. So
before
let me tell
biopsy,
you.
we will go for
So
before
if
the biopsy.
you so let me take your pathway. Okay. So if I send this patient for a CT guided biopsy, patient comes, we do a CT guided biopsy. Okay. And then we do a staging CT, and there is a lymph node, axillary lymph node present, which could have been there is an abdominal lymph node or a supraclavicular lymph node present, or there is an easy target, or there is a large metastatic lesion present, which is an easy target, and it will confirm two things. Number one, it will confirm the primary cancer as well, it will confirm the metastasis as well. So biopsying a metastatic lesion is more important than biopsy primary lesion. Okay, because it will confirm two things. It will confirm the metastasis, it will also confirm the origin of the tumor from the lung. So so it will be the pathway that you have taken, it will be completely wrong. So initial should be staging CT, then we will discuss about the biopsy, which
Okay, sir.
should
And
be
when the PET should be done? After biopsy, sir?
before
PET.
biopsy, ideally
Yeah,
before
yeah.
biopsy.
Okay, okay.
If
Right.
not possible, then after biopsy, yes. But ideally before
So,
biopsy, because it also
so
guides you.
So in lung cancer, what the PET would help us, like why it would help us, like on staging CT we have seen for the bones, we have seen for the organs. So how PET will help us in terms
Yeah.
of the uptake of the lung cancer to further categorize that it is which cancer type?
No, no, it doesn't tell you about the cancer type. It is not a specific investigation. PET-CT is a sensitive investigation. PET will help you regarding T staging. Sometimes there
Hmm.
is a tumor and there is surrounding hemorrhage or other tissue surrounding the inflammatory tissue around a tumor. So it will help you characterize the size of the lesion properly. So if we
Yes.
have staged a lesion on a CT chest, we restage it on PET-CT. And if you have two staging, one on CT chest and another one on PET-CT, we'll follow the staging of the PET-CT. It is
Okay.
important for PET. And also
It
there are
will
some
it will it will
bone
guide us
lesions.
for the biopsy, the site of the biopsy. It will guide us because there will be maximum uptake of the PET. We will do biopsy only at that site.
Yeah, it can also guide. This is another thing. And the third thing is that there will be uh, uh, in certain bone lesions which are not usually visible on a CT scan. PET is more beneficial in case of bone metastasis. It will help you in that. Okay. So for metastatic lesions, PET is more sensitive than the just the CT guided imaging, but you have to look at the CT images as well. So that's the importance of PET CT. In lung cancer, we'll go into detail of PET CT as well afterwards. So this should be the recognized approach for the okay. Acha, okay, can you go for a PET CT directly rather than a staging CT first in the context of suspected lung cancer? No, we always go for staging CT first, then we go for PET CT. It is because, as I told you, PET CT is a sensitive investigation, but it is not a specific investigation. So it might light up certain things. It might light up something in the bowel. It might light up something in the liver. So you need to have a staging CT first to see whether this is a simple cyst, a simple liver cyst, or something like that, rather than a metastatic lesion. Sometimes PET lights up a simple pericardial cyst. So PET before going for PET CT, you should do a staging CT first, and then we will do a PET CT, as well as everything that PET lights up. We visualize that on the original imaging, and then we decide whether it is really pathological or it is something physiological or functional. There are some areas which show physiological uptake on PET CT, and they should be ignored. Okay, I think I have answered both these questions. Okay, so they did some antibiotic therapy as well. The mass lesion is still there. How would you like to approach this lesion for biopsy?
Sir, if this lesion is lying, sir, can I scroll a little bit?
Yes.
I think I have remote control. Okay. This lesion is lying just behind the rib. So I'm not properly trained at lung biopsy per se, but I know that the lesion closer to behind the ribs are difficult to approach. But however, it is lying close to the pleural surface. Um, I can see the axillary artery also going that way. So I'm sorry, sir. I don't know how to approach. We could go from a posterior approach as well. I think ideally we should go from the posterior approach because anteriorly we have larger vessels, but I am not well trained at it, so I cannot comment.
Okay. So even if your description says that this is a high risk biopsy, you can say that if we want to go for a biopsy of this lesion, it will be a high risk biopsy because anteriorly there are axillary vessels, like you rightly mentioned. Posteriorly, you missed one more thing. There is this oblique fissure as well. So if you go through the fissure, you are going through an extra two layers of the pleura. So it
Okay.
will you. So if you're going through the fissure for a biopsy, you're going through four layers of pleura for the biopsy. It increases the chances of pneumothorax.
Hmm.
So it will highly increase the chance of pneumothorax. So this is a high risk. If possible, this will be a high risk a lung lesion biopsy if possible. Regarding that rib, because the CT scan is usually done at the end of inspiration, while you can change the breathing pattern in doing a CT guided lung lesion biopsy, and you can move the arms and things like that. You can change the position as well. You can do in prone, you can do in supine, you can do in lateral, so that you can move the ribs around. Usually, we are able to do biopsy.
Okay,
If the rib is surrounding the lesion, it's okay, no big deal.
so the approach would be posterior but high risk,
It is a
not
high
anterior.
it's biopsy, yes.
Posterior approach will go. So endobronchial biopsy, when we go for endobronchial biopsies? Can
When
we
the
do
lesion
in
is
such
central, when
central?
the lesion
Okay.
is central, not in this case. The bronchus won't reach here, so not in this case. Okay.
Okay. So which one is more invasive, subcutaneous or endobronchial? Which one radiologist or pulmonologist generally, you know, prefer that this biopsy should be done?
So if you have both options, we do a core biopsy, and usually endobronchial they take sampling. They
Mm.
take mostly do FNAC. Sometimes they also do core samples as well. But if you have a choice, I would always recommend a core biopsy, which we do.
Good
We
one.
take big cores, yes. Okay, so now going back to our presentation. So your approach should be logical, it should be systemic, it should be patient safe. Okay, you should know about the different things which are important in chest imaging. So you should comment on gender, age of the patient if you can see that. Don't ask for that. Otherwise, the examiner may get irritated and they may ask you silly questions. Then when the sternoclavicular giant fuse and other things fuse, so you can. Excuse me, I'm on call as well. Can I will take a call and I will just connect back. Okay, just give me 5 minutes.